Good afternoon to you all. Please let me introduce my PhD topic, which is the effects of maternal factors on the development of orofacial clefts. My name is Márton. Currently, I'm a dentistry student here at Semmelweis University. And as a PhD student, I envision to decrease the incidence of orofacial clefts and improve these patients' quality of life. And my mission is to indicate which maternal risk factors play a role in orofacial clefts incidence through the newest scientific data. I have two specific goals, more precisely two meta-analyses. The first one is about investigating the effects of deleterious habits and maternal health disorders on the risk of orofacial cleft development. It is a systematic review and meta-analysis. So we know that orofacial clefts are among the most common birth defects with an estimated worldwide incidence of around 1.7 per every 1,000 live-born babies. We know that it may differ between different geographical regions. And the babies born with these types of anomalies have feeding difficulties. They are often developing conductive hearing loss. They have speech problems, dental anomalies. And as you can see in the picture, they have aesthetic problems, which may lead to several psychological issues as well. And we know that from the literature that different maternal diseases during the first trimester of pregnancy are shown to play a role in the development of orofacial birth defects. So that's why our aim is to identify these maternal factors that may increase the risk of orofacial cleft development. We have the clinical question of, do maternal health disorders and deleterious habits during pregnancy increase the risk of the development of orofacial clefts? We use the PEO framework here, where our population is pregnant women. We have the exposures like maternal risk factors, more precisely smoking, alcohol consumption, obesity, diabetes, and hypertension. And our outcome is the prevalence of cleft lip and palate and cleft palate only. We hypothesize that some maternal health disorders and deleterious habits during pregnancy may increase the risk of orofacial clefting. And why is it important? Because using our results, these orofacial clefts will be diagnosed to a greater extent. And mothers in the first trimester will be more actively treated in order to prevent these clefts. Here you can see our systematic search. We conducted that in 3 databases with the search that you can see here. On the second domain, you can see that we tried to be as comprehensive as we could and list all the risk factors we would like to investigate and all the synonyms for it. And after the search, we have around 6,000 articles, and through the selection process, we have 72 eligible full text for the data extractions, which we are about to just start after this progress meeting. My second project is investigating the effects of pharmaceutical therapies during pregnancy on the risk of orofacial cleft development. It is also a systematic review and meta-analysis. We know that 14% of pregnant women fill at least one prescription for an opioid analgesic during the first trimester in the USA. And we know that odds ratios of developing cleft after the use of anti-epileptic drugs is about 6.6. And maternal corticosteroid use was associated with increased risk of developing cleft palate. And our aim in this study is to identify those medications that increase the risk of orofacial cleft development. Our clinical question is, do medications during pregnancy increase the risk of the development of orofacial cleft? Our population and outcome is the same just as in the previous study, but the exposures are medications, more precisely antibiotics, analgesics, steroids, opioids, folic acid. And our hypothesis is that some medications during pregnancy increase the risk of orofacial clefting. And the clinical implication of this study is that to identify those medications that should be avoided during pregnancy in order to decrease the incidence of orofacial clefts. Here you can see our systematic search. We use the same databases as in the first project and with the given search that you can see here. And to summarize the 2 of my projects, the planned submission date for the first project is about 2023 May, and the second one is June 2023. And I would like to thank you for your attention.
Thank you for the presentation. I would like to ask you about your second project. I know it's in an early phase, but if it's concerned with medication, probably the research includes risk factors as well. So that data from your second project may overlap or may be useful for your first project as well, right?
Yes, thank you for the question. It is right that so we have articles which investigate both risk factors and both medications as well, so we could use them with the same search key. Yes, so.
And Marci,
sure.
just one question related to your first project. For example, there is an obese pregnant woman with, for example, regular alcohol consumption. So I'm asking, what if, for example, not only one out of these possible risk factors are actually reported, but a combination?
Yeah, thank you for the question. At the early phase of this first project, we were thinking about that investigating those patients who suffers from two risk factors such as obesity or alcohol consumption and smoking are often investigated together, but we found only 5 or 6 articles which deals with this type of problem. So when they're investigating simultaneously these risk factors.
I also have a question. So I'm his co-investigator, so I read about the subject, and so far, from what I've seen, the administration of folic acid during the first trimester of pregnancy actually decreases the chances of a baby with cleft palate or cleft palate only. And my question would be, how would you differentiate the cases in which, for example, a pregnant woman would also take the folic acid during the first trimester of pregnancy and also, let's say, uses opioids or other medication?
Yeah, thank you for the question. It's a very good question. So we know from the literature that folic acid intake are shown to play a defensive role. So it significantly decreased the incidence of orofacial clefts. But yeah, that could be hard, to be honest, to investigate those pregnant women who take folic acid and other risk factors, such as opioids, which may increase the incidence of orofacial clefts. So we have to think about that.
You listed all those drugs which you think it's influencing the cleft palate development and so on. But I also wonder if antidepressants might be playing a role in this. In the US, this is like an everyday drug. People are eating like breakfast. But so did you see any of this?
Thank you for the question. Yes, you may be right. These medications I took from only the preliminary research. So we have to be more precise with the search key and surely involve more medications. And we have to be more precise, not just mentioning the search key antibiotics, but the most commonly taken antibiotics such as penicillin, macrolides, cephalosporins.
I saw you that you are going to investigate systematic diseases and also deleterious habits, but do you plan to investigate infections the mother has during the stage of the facial development?
Thank you for the question. Yes, maybe it could be my third project. So investigating acute diseases or acute infections precisely in the first trimester when the development of the cleft palate happens. So maybe it could be a third project for me.
Thank you, Marci, for your presentation. My question is regarding the exposures. Are you planning to make a subgroup analysis, or is it going to be a network?
Thank you for the question. Yes, we're planning to do a subgroup analysis, both regarding the type of the cleft, so cleft lip with or without palate and cleft palate only. And from the full text selection, I can say that we have enough data to make subgroup analysis regarding the type of smoking, such as active or passive smoking. So surely we will do subgroup analysis.
Just a very short question. Maybe you mentioned in the population that can you control somehow the age effects, or somebody can give a birth from teenager to late 40s if they want?
Yeah, thank you for the question. Yes, from most of the studies are case control studies where they investigate the maternal age as well. But from these studies, the data show that there is no significant difference between the ages. So that's why we wouldn't like to investigate that as a risk factor.